Good afternoon, doctors and friends. I'm Jennifer Luisa, student number 018, and we, SGDB8, are about to present our student project titled Update on Pathogenesis and Conservative Management of Acute Kidney Injury Patients. Here are the members of our group. Acute kidney injury is a group of syndromes identified by an abrupt decline in glomerular filtration rate, rapid rise in serum creatinine concentration, oliguria, or increased blood urea nitrogen concentration, also known as azotemia. This condition affects 10 to 20% of hospitalized patients and may exceed 50% in the intensive care unit, and it impacts 20 to 40% of COVID-19 patients in the ICU. AKI may cause major short-term adverse events such as fluid overload, electrolyte or acid-base disruption, uremic complications, etc. It is also associated with long-term conditions such as chronic and end-stage kidney disease and effects on other organ systems. AKI is even more significant in developing countries such as Indonesia due to the lack of availability of highly trained healthcare professionals and the lack of access to kidney replacement therapy. In these countries, women and young adults are more at risk of death and decrease in quality of life, causing a high economic burden. Therefore, we would like to review the update on pathogenesis and conservative management of acute kidney injury. Here are our formulation of problems, objectives, and benefits.
Kidney physiology. So kidney has some function. It's like maintain homeostasis, excretion and secretion. Glomerular filtration rate is widely accepted for the best index of kidney function, but it is difficult to measure and usually estimated from the creatinine serum level. Urine output also sensitive for the kidney function and a biomarker of tubular injury, but the relationship between urine output, GFR, and tubular injury is complex. And referring to KDIGO, AKI or AKI is described as a sudden loss of kidney function and can be determined by the increase in serum creatinine by 50% or more within 7 days, or increase in serum creatinine by 0.3 mg per deciliter or more within 2 days, and oliguria for 6 hours or more, and this condition limited within 7 days.
My name is David, number 74. I will tell about etiology of acute kidney injury. So there are three categories: prerenal, renal, and postrenal. So the prerenal is the most common injury that 70% caused from prerenal. In prerenal, the function is normal, but there are problems in perfusion, that is decreased perfusion. The cause of prerenal injury can be from intravascular disease, arterial pressure decrease, a history of chronic kidney disease that lead to prerenal acute kidney injury, medication like NSAID, ACE inhibitor, and ARB. Then the second, from renal, it's injured kidney components itself. The most hospitalized intrinsic patient is acute tubular necrosis that caused from nephrotoxic and ischemic. Then the second, there are glomerulonephritis that is inflammation of glomerulus and blood vessels that cause from systemic disease. And the third, there is acute interstitial nephritis. It's a renal problem that caused commonly by medication. And the third etiology of acute kidney injury is from postrenal. The postrenal injury mostly caused by urinary tract obstruction, mainly by prostate enlargement that very common in old men, and postrenal injury mostly can be treated if the obstruction cleared. Next, I will tell about diagnostic and follow-up of acute kidney injury. The diagnostic criteria, it cannot be based on sudden symptoms that we can see it from score that glomerulus filtration rate is the best to measure renal function. How to see glomerulus filtration rate? We can see it from creatinine. The increased serum of creatinine, it means worse condition from acute kidney injury. Another measurement to see diagnostic criteria for acute kidney injury, we can see urine output. Urine output itself can see can be biomarkers of tubular injury. It's different between adult and children. In adult, the old measurement we use a rifle and a can to measure from serum creatinine and urine output of the patient. And the new measurement using 2012 KDIGO that why it benefits cause it more simple. Don't need fluid resuscitation before to show urinary obstruction. And in children, uh, it's different from adult cause. Serum creatinine is difficult to measure. Cause in children, the muscle still not develop perfectly. So there's only a little muscle that make creatinine is difficult to be measured. So there's new diagnostic criteria specific for children named P-rifle that we see increased creatinine level, decrease in GFR, or decreased urine output. Uh, P-rifle can use in children more than 1 month. That's all from me. Thank you.
Hello, my name is Nicole Putario Kamanaputri, register number 65. So I will tell about the risk assessment and the markers of acute kidney injury. Every individual has a different chance of developing acute kidney injury after exposure because every individual has a wide variation of suspectibility factor number. Acute risk assessment is using 4 simple steps that is called Fantastic Four. The first simple step is the F1 or clinical scenario. Things that should be reviewed and considered in the clinical scenario are the patient's signs and symptoms, risks and surrounding circumstances. The F1 acute risk factors include major or cardiac surgery, polytrauma or burns, sepsis, diarrhea, coronary angiography, vasopressor, contrast media, and medication such as ACE inhibitor, ARBs, NSAID, aminoglycosides, and vancomycin. The next step is F2 or 5 history. The risk factor of acute kidney injury in F2 are patient is older than 65 years old, bed race, from a low-income country, has BMI greater than or equal to 30 kilograms per meter square, hypertension, diabetes, chronic kidney disease, previous AKI, liver or lung disease, heart failure, cancer, medication, and other nephrotoxins. The next simple step is F3, which is physical examination. The risk factor of AKI found in physical examination are hemodynamic instability, peripheral urium, acid test, RELS, dehydration, and urinary output, less than or equal to 0.5 milliliter per kilogram per hour. The last step in the Fantastic Four is the laboratory results that include possible AKI biomarkers. The lab results that have risk in acute kidney injury are anemia, hematuria, proteinuria greater than 300, estimated glomerular filtration rate less than 16 milli, and serum creatinine greater than 1.5 milligram per deciliter. So the next one is the markers. AKI biomarkers are well if the damaged kidney and should be able to detect the AKI before the increasing level of creatinine. The biomarkers of early diagnosis of AKI are urine interleukin 18, urine neutrophil gelatinase associated lipocalin, kidney injury molecule 1, brush border enzymes, cystatin C, and urine liver fatty acid binding protein or LFA-BP. Interleukin 18 is produced by mononuclear cells, non-immune cells including proximal tubule cells and macrophages. And based on study on mice, it shows that increased expression of interleukin 18 in the kidney and inhibition of interleukin 18 protect mice from developing AKI. The next biomarker is urine NGAL. It is a polypeptide and it is resistant to protease, so it might easily detect in the urine. NGAL has a role in bacterial infection innate immunity. Study shows in rat and mice that the level of NGAL protein is increased a lot in the renal tubule, and the existence of this biomarker in the urine preceded beta-2 microglobulin and N-acetyl beta deglucosaminidase tubular protein in after ischemic acute kidney injury. The next biomarker is KIM1. There is a great increasing of protein in KIM1 mRNA in a post-ischemic kidney. Meanwhile, in the normal kidney, these biomarkers are expressed at a low level. KIM1 increased 3 to 5-fold in cheese plastin induced rat and preceded other marker. The next biomarker is brush border enzyme. In acute and chronic kidney injury, the concentration of alkaline phosphatase and gamma glutamate transferase is increased. But there are some conditions that cause the increase of tubular enzymuria too, such as acute tubular interstitial nephritis and acute rejection. The next biomarker is cystatin C. Serum cystatin C preceded an increase 15% in serum creatinine, so that serum cystatin can detect AKI earlier. And the last biomarker is urine LFA-BP. It is a 15 kDa protein, and in human it is expressed in the proximal tubule. It becomes a sensitively early biomarker to AKI post-cardiac surgery. Besides post-cardiac surgery, severe septic shock patient also has increasing urinary LFA-BP.
My name is Ana Agung Ayu Ratendra Putri, and now I will explain the pathophysiology of AKI. AKI is the condition where kidney is failed to maintain the electrolyte base, water base, and also the acid base in the body. The cause of AKI is complex, but generally it was caused by sepsis and also ischemic. In ischemia, inadequate delivery of oxygen and metabolic substrate can lead to the organ dysfunction. Renal is the organ that is sensitive to the injury caused by ischemia. It can be explained by the structure of the renal tubules and the blood vessels in the outer medulla of kidney, with ischemia impairing blood flow to the inner nephron structures. After a massive decrease in renal perfusion, ATP failed to maintain the epithelial cell, which can lead to severe apoptosis and necrosis. If the function of nephrons to absorb other substance is not fulfilled, it can cause a toxic surrounding the epithelium. In addition, AKI is common in sepsis. When sepsis occurs, metabolic become hyperdynamic and blood flow changes, although not always in the ischemic range. DCR falls rapidly and involves inflammation, oxidative stress, microvascular dysfunction, and amplification of acute renal injury. AKI in human is multi-causal. Sometimes it has special cases such as rhabdomyolysis. Rhabdomyolysis is associated with 10 until 30% in the cause of AKI. Rhabdomyolysis is the condition when there is a breakdown of skeletal muscles and it release of the content of skeletal muscles, such as myoglobin, sarcoplasmic protein in the extracellular fluid and circulation. Furthermore, this product is filtered by the glomerulus and cause AKI. Drug is common cause in AKI in hospitalized and intensive care patients. Some drugs can cause acute tubular injury due to its toxicity. Cidofovir and tenofovir are drugs that is dose-dependent, associated in 12 until 14% patient with AKI. In mitochondrial red cells, this drug inhibit mitochondrial DNA polymerase, causing the decreased mitochondrial DNA, resulting structural change in mitochondrial and that result apoptosis in kidney. In addition, NSAID is also associated with acute renal injury.
My name is Bella Trisagusarhoti, number 152. Distinctions between acute kidney injury, acute kidney disorder, chronic kidney disease, and no kidney disease. Acute kidney injury, or AKI, is part of the conditions that affect kidney function. This condition is summarized as acute kidney disease and disorder, or AKD. Even without the rapid onset criteria of AKI, AKD can still occur. For example, when renal dysfunction develops slowly. The condition when AKD persists for more than 3 months is called chronic kidney disease or CKD. Both AKD and AKI can occur in patients with or without previous CKD. The condition when there is no functional or structural abnormality is called no kidney disease or NKD. The criteria for defining AKI, AKD, CKD, and NKD differ from one another. These criteria can be seen in the table below.
Hello, my name is Shantika Piyaramawati with my serial number 106. So for the volume status, the goals of knowing patients' volume status in patient with acute kidney injury is assessing fluid need, so we can optimize fluid status and hemodynamic by achieving fluid balance. Patients with acute kidney injury often develop oliguria, which leads to volume depletion, so therefore fluid resuscitation is a cornerstone of the therapy, and it can be beneficially needed for patients with poor clinical status or shock. In the other hand, worries of fluid overload that happen by providing inappropriate amounts of fluids are something should be avoided by clinicians when treating patients' acute kidney injury in hospital. Those are the consideration of assessing volume status. There isn't specific parameters to determine clinical outcome of acute kidney injury. That's why it should be performed individualized in determining the right amount of fluid to be given. It is also advised to evaluate vital signs and physical examination in assessing volume status. If volume status is to remain unclear, it's suggested to administer an IV fluid bolus of 500 ml of isotonic saline earlier for 4 to 6 hours with assessment of volume status, urine output, and SCC and eGFR within 8 to 12 hours. Next is hemodynamic management. Some assessment for hemodynamic are hemodynamic status evaluation through vital sign and physical examination, and also shock monitoring through arterial line, central venous pressure, or cardiac output monitoring. This advice to achieve certain mean arterial pressure, or MAP, as the target of hemodynamic management. MAP for patients with normal to mild condition is 65 mm of mercury, then to maintain kidney function is 75 mm of mercury. Meanwhile, for patients with septic shock, there's standard rule, which is 65 to 70 mm of mercury, and there's also high rule, which is 80 to 85 mm of mercury. Vasopressor administration is the hemodynamic management and should be performed individualized, with the first line choice is norepinephrine, which is known in increasing global and medullary pressure effectively and obtains higher diuresis outcome.
Good morning, doctors. My name is Vanessa Els, student number 121. Nutritional therapy should not be neglected in acute kidney injury patients due to concern of increased urea in the body and antecedent need for renal replacement therapy. The main aim of nutritional therapy is to give adequate intake of energy, vitamins, micronutrients, and macronutrients to modulate increased catabolism while nurturing lean body mass. Adequate nutrition should be given via enteral route to restore nutrition as it is preferred, widely used, and well tolerated. Enteral nutrition could aid in maintaining gut integrity and preventing bacterial translocations, but in several conditions, parenteral nutrition could be given, and it is still highly recommended that enteral feeding is pursued before giving parenteral nutrition. The recommended calories intake start from 25 to 30 kilocal per kilogram and a protein contributions of 1.5 to 2 gram per day in acute kidney injury patients without renal replacement therapy, and a maximum of 1.7 gram per day in hypercatabolic patients to prevent malnutrition, which is highly prevalent in acute kidney injury and risk factor for increased mortality. If uremia is found, renal replacement therapy could be used as a substitute for fulfilling nutrition requirements to prevent uremic exacerbation. If patients are in the recovery phase, water, amino acids, and electrolytes should be limited for the sake of dialysis until the renal function restores. If a patient have a high residual GFR, a high amount of nutrients should be given as there is a minimum risk of water and electrolyte disorders. Lastly, fluid overload and hyponatremia conditions should be avoided in planning nutritional therapy for acute kidney injury patients.
My name is Fiorella Angelina with my last 3 digit of student number is 084. So maintaining body homeostasis and biochemical abnormalities correction should be the primary goals of acute kidney injury treatment. A variation of complication may arise in acute kidney injuries such as uremia, body fluid imbalances, and metabolic acidosis. And change in urinary acidification mechanism is found as the kidney is unable to excrete potassium and then fails to reclaim the sodium. This condition or severe acidosis could be improved by giving bicarbonate, as it is also essential as pre-dialysis treatment. Another metabolic condition that is often found is hyperkalemia. It is caused because the kidney is unable to excrete potassium and hydrogen, and this condition is manifested as distal renal tubular acidosis, which leads to hyperkalemia but adequate or low levels of aldosterone. And this condition, hyperkalemia, could be life-threatening. So serum potassium must be lowered by decreasing the potassium diet intake, exchanging potassium across the gut lumen using potassium binding resins, inducing transcellular shifts by giving insulin, dextrose, and beta agonists, and also regulating dialysis. Lastly, the hyperglycemic condition could also be found in this kind of patient. Therefore, the hyperglycemic kidney damage prevention must be done by maintaining the blood glucose between 110 to 149 milligram per deciliter.
My name is Alin Tiraldiakema with student number 097. Next is about the follow-up treatment. So the follow-up treatment of patients recovering from acute kidney injury or AKI is made based on the guidelines by KDIGO, the Kidney Disease Increasing Global Outcomes Organization, which states that it is highly recommended to evaluate patients 3 months after recovering from an AKI episode. First of all, the evaluation focuses on suppressing the risk of subsequent pathological events or sequelae. There are sequelae that affect kidneys, such as CKD or chronic kidney disease, end-stage renal disease or ESRD, and recurrent AKI. On the other hand, there are also some sequelae that affect other organ systems and other aspects of health, such as hypertension, stroke, myocardial infarction, recurrent hospitalizations, and the decline in the quality of life. So the treatment should also concentrate on managing pain and the kidney functional status, as well as the goals of the care in the future, rather than simply focusing solely on their survival in order to improve the quality of life. Also, the follow-up treatment assesses and monitors the injured kidney recovery and taking some precautions of new onset and or progressive chronic kidney disease. The follow-up intensity should be personalized based on the existing risk factors in each patient and also the clinical features of their AKI episode, as well as taking in consideration how well their injured kidney has recovered. The major risk factors include undetected chronic kidney disease that might have previously existed, AKI that requires dialysis, as well as kidney condition that cannot reach the baseline level of its normal function. So better outcomes after recovering from AKI are expected to be achieved by focusing on some care elements, which can be seen on the table below. First of all, precautions against chronic kidney disease complications must be taken. These include reviewing the fundamental laboratory studies, such as serum creatinine, hemoglobin, urine albumin to creatinine ratio, electrolytes, calcium, and phosphate. Also, we should monitor the level of proteinuria, or we can measure the level of urine albumin We should also take care of the volume management, metabolic control, and we should be aware of when to prepare for dialysis. Moreover, cardiovascular risk with their possible complicating events also need to be controlled. For example, by monitoring blood cholesterol level and the blood pressure. As for the medications of the patient should also be reviewed. It is essential to record medications that are recently prescribed for the patients, find out which medications have been stopped, and make sure that the dosing does not overwhelm the current kidney function. And we should also check the patient's understanding of their drug regimens in order to assess their compliance in taking the drugs and the medications. As for the comorbidities, such as the cardiovascular diseases, stroke, or diabetes, we should also refer them to the corresponding specialist.
And now the complications of acute kidney injury conservative management. The first one is fluid overload. According to the KDIGO guidelines, one of the clinical signs of acute kidney injury is oliguria. Based on this condition, it is common to start a treatment by giving fluid administration. But sometimes the fluid administration doesn't have the beneficial effect. This fluid administration can lead to positive fluid balance that result in fluid accumulation. Based on the latest study, patients with fluid accumulation has less likely to recover renal function and has higher mortality rate. The second complication is antimicrobial therapy complications. It can happen on sepsis-induced acute kidney injury. There are several difficulties on determining the correct individual antimicrobial doses, so sometimes it can lead to overdosing or underdosing the antimicrobial. This condition can lead to the increased therapeutic failure, and then the patient can also have higher mortality rate and also the emergence of antimicrobial resistance.
So the next one is the conclusion. Acute kidney injury or AKI, or also known as acute renal failure, indicate reduction in kidney function and often reversible in a sudden onset. AKI can be divided into three categories based on the part that are injured, such as prerenal, renal, and postrenal. The best index to measure renal function is glomerulus filtration rate or GFR, and to measure GFR can be predicted by using endogenous filtration markers, for example, creatinine. AKI risk assessment uses four simple steps called the Fantastic Four. AKI is a condition when kidney function declines acutely and is unable to maintain electrolyte, acid base, and water balance. AKI can be caused by ischemia, sepsis, and drug-induced, and the volume status assessment of the patient is a main strategy in optimizing hemodynamic by achieving fluid balance. Hemodynamic monitoring is crucial for patients with AKI, such as arterial line, central venous pressure, or cardiac output monitoring. Water acid-base balance, electrolytes, carbohydrate, protein and lipid levels in AKI patients should also be assessed to give adequate intake of energy, vitamins, macronutrients, and micronutrients to modulate increased catabolism while nurturing lean body mass. The follow-up treatment of patients after AKI is essential to be planned and highly recommended to evaluate patients 3 months after an episode of AKI. The complications that can occur in conservative management of AKI patients are fluid overload, underdosing, and overdosing of antimicrobial drugs. So that's all about the students' project presentation by SJDB 8. Thank you so much for the attention.